Well, welcome everybody for the June 2024 Barrier Busters meeting. I'll be hosting for a change. Stacy is unfortunately out sick. And to start us off with, I believe we've got Trevor Brooks from the Cancer Support Community. The Cancer Support of Ann Arbor.
Hey, nice to be here.
So, Trevor, you can start whenever you want. Did you want to drive your slide deck, or did you want me to do that?
I think I can do it. I'll share my screen if that's all right, and begin. Yeah. Just let me know if you can see this all right. Okay, good. Okay. Well, hello everyone. Good afternoon. Thank you for having me. My name's Trevor Brooks. I am a social worker by training and also the Associate Program Director of the Cancer Support Community of Greater Ann Arbor. Today, I'm happy to go over what the Cancer Support Community is, talk a little bit about the programs that we offer, and go into some of the specifics regarding those programs. So I'm just going to start with just some overview, essentially. CSC, as you'll hear us refer to ourselves, uplifts and strengthens people impacted by cancer by providing support, fostering compassionate communities, and breaking down barriers to care. A couple things to know about us. We have an office here in Ann Arbor off of Hogback Road. We'll talk a little bit about where some of our programs actually take place in addition to that office. We're a nonprofit. We opened up in 2007, and we're actually part of a larger national network. Even though we're our own independent individual community here, or organization rather, you'll find different cancer support communities. For example, there's Gilda's Club, which is essentially the same thing. Gilda's Club Metro Detroit, as well as Gilda's Club Grand Rapids, and many others throughout different states in the US. What all of these organizations have in common, but particularly looking at us here in Ann Arbor and the greater area, we have free programs designed to combat three major stressors of cancer: loss of hope, loss of control, unwanted feelings of aloneness. All of our programs are evidence-based, professionally facilitated. For the most part, that's going to mean licensed social workers. They are free of charge and available for the whole family the whole time. And so what we like to say is it's available for anyone impacted by cancer. It casts a rather wide net. So that could mean you are a parent of someone with cancer, you are a child of someone with cancer, you are a patient yourself or a support person, and so on and so forth. It does not matter if it is just after diagnosis or if it is after someone finishes their primary treatment. There are lots of challenges along the way, so our programs are designed to capture some of those challenges and address them regardless of where someone is in their cancer experience. Like I said, our main center here is in Ann Arbor. However, we partner with Trinity Health, particularly what we call our off-site programs in Brighton, Canton, Chelsea, and Livonia. This is something that I think a lot of us have experienced, though. Our programs, due to COVID, moved all online for a couple years there. And 2 years ago in June, we got back into our hybrid programming. So what we'll see with some of the things I go over is you can join over Zoom, you can join in person, or some combination of those two. really depends on what the program is. We're often trying to respond to what our members are interested in to make some of those decisions, whether we do it virtually or in person. As a general overview of what these services are, I'm just going to go just big picture here and then get into some specifics. Support groups are kind of the backbone of the more mental and emotional support services that we have. We offer usually around 2 educational workshops a month and weekly lifestyle classes. I'll get into that a little bit. In our name, cancer support community, and we think social events are a really important part of building that community. So either we have weekly groups or family events that are every month that we host here in our center or elsewhere. We also have oncology social work staff that do more traditional short-term counseling, and we're starting to expand that a little bit actually to include someone that's here full-time in Ann Arbor at our center, as well as someone that is at Trinity in the actual cancer center. We also have individual support. And oftentimes this means referring out to other communities. Folks come to us with a whole host of different issues, not related to cancer necessarily, but certainly impacted by it. And so we often rely on other community organizations to refer out, and we'll work with someone to find the right thing for them at that time. And then lastly, practical assistance. We think of financial assistance as well as a lodging program that we have that I'll talk about a little bit further. The specifics of those programs, thinking about those support groups, we have weekly support groups, again, open to anyone. And the name of the group will give you an idea of who it's for and who are the members. Typically, a living with cancer, this is open to any diagnosis, or family and friends. As long as someone in your life has been diagnosed, you're appropriate for that group. We do have some groups that are targeted around specific topics or phases in someone's experience. So Cancer 101, some basic information about cancer. Survivorship transitions, this is when someone's moving into more of the survivorship phase after they've completed their treatment. We have a group for dyads, so couples that are looking to face cancer together and work on communication and so on. And then we're really trying to build out our kids support, teens, and parents, and how parents talk with kids regarding their diagnosis or other medical related issues regarding their cancer. Some of our other groups include diagnosis specific groups. You'll see blood cancer, breast cancer, head and neck, etc. Some are related around identity pieces and how that interacts with cancer and their experience. So you'll see we have an African American fellowship. We have a pride group, we have a young adult group, we have a more grief-oriented group, living with loss, and so on. Beyond those programs, the support group programs, I mentioned lifestyle classes. We have these multiple times throughout the week. Yoga, Tai Chi, Pilates, Zumba, Reiki, more nutrition-based class, cooking for wellness, meditation, and so on. These are really targeting not only the physical components, but some of the mental and emotional effects of cancer. And so this speaks to both of those things. In these locations, you'll see if you have someone that you want to refer to us, but they're located not in Ann Arbor, but in some of the surrounding areas, We do have support groups and weekly yoga classes, for example, educational workshops at these Trinity Health Cancer Centers. And in terms of the workshops, like I said, there's about 2 each month. So upcoming for us, so we have one tonight on managing GI symptoms, one about why can't I stay positive during your experience, one on Medicare 101, cancer-related fatigue. We often record these and we'll post them on our website for folks to look at later. And these are presented by experts in the field. So we'll often partner with physicians, other healthcare workers, and so on to talk about their expertise for these topics. Social programs, as I mentioned earlier, include things like potlucks and picnics, events out at Gallup or surrounding parks, holiday parties, paint parties, weekly coffee and conversation, more creative type social activities. So a whole list of things, and we're often trying to include new things that will draw people's interest to get together either in person or virtually. The one-on-one support, this is short-term counseling with either our staff here or our oncology counselors. If that is not appropriate for someone, maybe they're dealing with other things beyond their cancer experience, we often refer out to the community and try to get them set up with the appropriate individual. The practical assistance I mentioned earlier, this is something that I think personally I'm really proud of. We're often finding people call us with just basic needs around paying for their bills. We don't offer financial assistance for medical bills. However, something called our Sprout Love Financial Assistance Program, we're able to offer up to $2,000 a year to go towards other expenses. That could be someone's rent, their mortgage, grocery bills, utilities, anything that they need some assistance for. It's open to patients and caregivers. And to qualify, you have to essentially make less than 400% of the federal poverty line for the state of Michigan. So in layman's terms, it's actually a pretty generous eligibility. You can be doing okay, financially speaking, and still qualify. We know this is a really stressful, challenging time, and there's a lot of moving pieces. Often people take time off from work to focus on their treatment and so on. So if someone's interested in this in particular, we'll work with them to see if they're eligible and award up to that amount. Additionally, this is something that we've started within the past year. We have funding through partnership with the American Cancer Society. We also work with U of M to provide lodging assistance for up to 21 days. These are folks that are coming here to our area for their cancer treatment, but they might be traveling from the Upper Peninsula or really any place that's outside of 30 miles from their treatment center. And as long as it's in our service area, we are able to pay for their lodging at like a hotel or motel. We have certain partners that we work with that will refer people to, and so they can stay there. We'll cover the cost, and they can perhaps take a shuttle to the cancer center, or we'll arrange transportation in some manner. And so they won't have to worry about the travel, particularly for those cases where someone is receiving radiation 5 days a week. And it's just really challenging to have to travel back and forth from long distances. That's really the breadth of our programs, but who we serve, typically, we've seen this increase, but typically we're serving around 1,100 people a year. That includes adults, children, caregivers, family and friends, as well as healthcare professionals who join our workshops for education. Again, any age, any stage, from the moment of diagnosis through survivorship or bereavement. For the most part, it is adults with cancer that we're seeing. That brings me to the end, but I don't know if we have time for questions. If anyone has any follow-up or questions that they have, happy to answer anything. Additionally, you see my contact information there, my email, our office number. Always happy to talk through any specifics. Or if you have a client that you're working with, for example, and you want to talk through some things, that's what we're here for. Thanks.
All right, thanks so much, Trevor. Really appreciate the breadth and depth of all the things your agency is doing. I had just a quick question. So when you're talking about financial assistance, are these for individuals or clientele that's already connected to the center, or are these just people that are calling in, at large?
It can be both. Someone doesn't have to attend our programs or become a member necessarily to access those services, or that financial assistance rather. So we have people that know about us in the community, and so it's a little bit easier. They're already familiar, but we often get referrals from, say, social workers in the hospital that say, hey, I have a client. Do you think they'd be eligible? Can we submit an application? And the application process is pretty streamlined compared to a lot of different types of grants. So we'll work with anyone as long as they meet those eligibility requirements.
Thank you. All right, well, thanks so much, Trevor. I don't see any other questions, no raised hands, nothing in the chat. So we'll be moving on to our next presenter. Sherry Smith over at Ageways is going to talk a bit about the Michigan Medicare Assistance Program.
Good morning, everybody, or good afternoon, actually, everybody. I'm trying to get my video back on. Thank you for having me here. I know I was here a few years ago and spoke, but people change, a lot of turnover, programs change. So I'm going to talk to you a little bit about the Michigan Medicare Assistance Program, and I'm going to focus a lot on some of the low income options that we offer through Medicare that might help you with your clients. So I'm going to share my screen. Maybe I'm going to share my screen. Where's share? Okay, there we go. Okay, can you folks see the screen? I know it's not in slideshow, but yeah. Okay. Put it in from the beginning. Okay, so this is the map, which is the Michigan Medicare Assistance Program. Some of you may notice that we dropped the word Medicaid from our name. We used to be Michigan Medicare Assistance Program, but with the public health emergency unwinding, we started getting calls from people on Medicaid with, who were pregnant women and, younger kids, and it's not a population that we serve. We only serve older adults who are both on Medicare and Medicaid. So we dropped the Medicaid from our name, and it cut down by about 200 calls a day. literally. We also, some of you may notice that the Area Agency on Aging 1B has also changed its name to Ageways Nonprofit Senior Services, which is more reflective of the work that we do and is easier to say. So, so that's where we are. So I'm going to do a brief kind of Medicare 101 and to start with how people can enroll in Medicare, that if you're not getting Social Security or railroad retirement benefits, it's not automatic. And for example, if you're still working. And the 3 ways that you can enroll in Medicare are by visiting a local office, calling, or enrolling online at ssa.gov. It's really easy to enroll online. When you go to ssa.gov, there's a big box that says Medicare, and you click on it and you just keep following the links. It's really, I have to applaud them for making something very simple for people. And if people are getting Social Security, they should get a card when they first turn 65, or 3 months before they turn 65, actually, or after they've been on disability for 24 months. And those are the 2 primary ways that you get on Medicare, is when you turn 65, or when you've been on disability for 24 months. So the Medicare card has changed a lot since some of you may have seen it. It's now got an 11-digit random number. It used to be the Social Security number, and Medicare changed that because of identity theft. What's nice about this number is that there's no identification between who you are and the number on your card. It's a completely random number that's assigned just to the individual. The good news is if they lose it, they can get a new card. Or if the card's been compromised by someone, you can get a new card where you couldn't get a new Social Security number. So this was also progress. So briefly, there's 4 parts of Medicare, and I'll go into each of these in a little bit of depth. There's Part A, which is your hospital insurance and hospice skilled nursing facilities. Part B, which is your medical insurance, so your doctor's appointments, outpatient, outpatient medical, a lot of preventive care. And those 2 are what we call original Medicare. And that does not include drug coverage. So if you get a Part A and a Part B, you also need to get a Part D, which is Medicare prescription drug coverage. And that's the big thing during open enrollment, which starts October 15th and ends December 7th, is to look at your Part D plans. And Part C is a Medicare Advantage plan, and those are HMOs and PPOs that bundle A, B, and generally D into one plan. And those are what you see most of the advertising for on TV. So when you're first eligible for Medicare, there's some choices that you have to make. And it's really what path you want to go down. Do you want to go down the original Medicare path, which is your Part A hospital, Part B medical, and adding a Part D? And then you can also add what's called a Medigap plan or a supplement. And those help pay for your out-of-pocket costs in original Medicare. Or you can get a Part C, which is a Medicare Advantage plan, again, that bundles A, B, and D together. What's important about this choice is that you have a 6-month period of time to get a Medigap plan when you first go on Medicare and get your Part B, as in boy. During that 6-month period, Medicare can't, or the insurance plans rather, cannot underwrite you. So they can't look at any medical conditions that you're coming with. They can't look at where you live. They can't look at anything. They just have to offer you the lowest prevailing rate. So you could be a cancer survivor. You could have active cancer. You could have a heart condition. they have to offer you the lowest rate. After that 6-month period is done, they can underwrite you, which means that they can look at you, they can look at all your medical information, and they can say, you know, you have A, B, and C, therefore we're going to have to raise the price of the insurance because it's higher. You're a higher risk for us, or perhaps you might not even be insurable at all. So it's really important when people are first eligible to understand the different paths. You can change, and it's possible to get a plan later, but the risk of having a higher cost is really pretty present. So to understand Medicare, it works with private insurance companies for both Part B and D. It has well-defined benefits and exclusions, so there are certain things that it will cover and there are certain things that it won't cover. And if you want something covered that Medicare doesn't cover, it pretty much takes an act of God to get them to cover it. I've seen it done, but it's not easy. Part D does not cover vision, dental, or hearing, except under very specific circumstances. And those are usually when it becomes really a medical, surgical situation. Part C, which is the Medicare Advantage, generally does cover vision, dental, and hearing. Some of those plans cover it more extensively, and some cover it less. Part D does not cover over-the-counter medications. Part C often gives people a stipend or a card to cover some over-the-counter medications. And neither Part D or Part C cover long-term custodial care, which would really be nursing home care. That's when somebody would either have to be private pay or Medicaid. So for a little more depth, Part A is the hospital, and it covers hospital insurance, skilled nursing, home health care, and hospice care. It's generally free for people who have worked for 10 years and have put into the system, although there is a $1,632 deductible. If you have a Medicare Advantage plan, that would cover your deductible. Part B, the medical insurance, as I mentioned, it's the doctors, the hospitals, clinical lab services, preventive services. And in the absence of a Medigap plan or Medicare Advantage, that's an 80-20 plan. So you're going to pay 20% of the cost of care, and the government will pick up the other 80%. To have a Part D plan with original Medicare, you have to have Part A and B or B. You have to live in the plan's service area. You can't live outside the US. You can't be incarcerated. You must enroll in you have to enroll in the plan. It's not automatic, and you have to fill out an application. The good news is we can help people fill out applications. We work both virtually and in person, and we can help them do their applications right online. I do want to say a word about people who are incarcerated, because I don't know if anybody works with the newly released population here, but they get really hit very hard because their Medicare stops when they're incarcerated, and then they have to pick it up again when they're released. But because they stop their Medicare, they will incur a penalty for that right now is about 34 cents for every month that they should have had both Part B and Part D and didn't have it. And that gets tacked on to the premiums that you pay for Part B, which right now is $170.70, and Part D, which will vary. And that penalty sticks with you for life. So these folks are coming out of prison, having to get Medicare and getting hit with a penalty that they had no control over, because the government says you stop paying for, you stop your Medicare when you're incarcerated because you get whatever health care the prison system gives you. So you really get hit hard because here you are, you can't probably find a job and you have a penalty on top of your Medicare. So I just wanted to put that out there, and that's something that we can't really help people with that, but we can help explain it to them and see if there's other ways to get services for people. So Part C really works the same way as Part D in terms of you hit their private company health plans that are approved by Medicare, run by private companies. They're capitated though, so Medicare pays a certain amount for each member's care. And the same rules though for Part D apply for Part C. And you often have to use the network of doctors and hospitals that the company provides. So these are the HMOs and PPOs. And these are the ones that you really see advertised on TV. And we really discourage people from calling those numbers. They're generally not the best plans for people. Part C, you still have all the rights and protections that you would have with an A and B plan. You still get everything that A and B provides. Most plans include a prescription drug coverage, and as I mentioned, most of them have vision, dental, or hearing, but the benefits and cost sharing might be different. So you may end up paying 20% for a visit, or 40%, or it may be a dollar amount, $50 every time you go to see a specialist, for example. And all the plans vary, which is why we encourage people to come to us and get individual one-on-one counseling for their specific Medicare needs, and we can help them out. I say this at the end, but I'll say it here. We are not licensed to sell any insurance products. We can enroll people in plans, but we don't get any commissions, and we cannot sell people anything, but we can enroll them. And so we provide 100% non-biased care for and counseling for people. So when can you enroll? You can enroll if you're new to Medicare during your 7-month initial enrollment period. This will be for people generally taking Social Security, which is 3 months before you turn 65, the month you turn 65, and 3 months after. There's also special enrollment periods. So for people who are still working, for example, if they have what's called credible coverage, which is coverage that is at least as good as what Medicare provides, and if they have that through their employer and their HR person would know if it's credible, there will be no penalties if you don't enroll during this period. We get a lot of calls saying, I'm still working, I've got great health care, do I have to enroll in Medicare? Well, no, you don't. And then you'll get a special enrollment period. You can change your plan every year between October 15th and December 7th. That's the open enrollment period. And coverage starts January 1st. We encourage everybody on Medicare to look at their plan or call us, and we'll help you look at your plan because all sorts of things change. Doctors can change, your medications can change, your income can change, your needs can change. And we want to make sure that every year you're on the best plan possible for you that is at the lowest price and provides everything that you need. And then there's also special enrollment periods for low-income people and voluntary loss of coverage. For example, you lost your job or if you move out of the plan service area. And you can join a plan by calling them, by calling Medicare, or going online or calling us. And our phone number will be at the end. So Medicaid and Medicare is kind of complicated, but if you're eligible for both, it's called being dual eligible. Medicare will pay for whatever costs come first, and Medicaid will pay for whatever Medicare doesn't cover or partially covers. Oh, and I'm sorry, I forgot to take this out. I did a presentation for the Ryan White group the other day, and Ryan White's the payer of last resort. But actually Medicaid in this case is the payer of last resort. Many dual eligibles may qualify for special needs plans or SNPs. This is something that Medicare is pushing and Medicaid is pushing. It's going to start getting really big in the next couple of years. They're HMOs or PPOs. They're often tailored to a specific chronic condition. So there may be a SNP that's for people who have diabetes, for example. And they will provide more services than a regular HMO or PPO. And as always, a MAP counselor can help people find the appropriate plan for them. And programs that can help people save additional money if they're at lower income. And I wanted to first go over just a couple definitions because people get confused by these. And they're great to hand out to the people that you work with because it's just a nice visual, I think. The premiums amount that you pay for an insurance policy, and it's generally monthly. So for example, the Medicare Part B premium is $170.70 monthly. The deductible is the amount you pay for your out-of-pocket costs for healthcare before the plan begins to pay. So if you've got a $250 deductible on your drugs, you have to pay that much in drug costs, and then your plan will pay. The copay is the rate you pay for prescriptions or doctor's visits, and that would be a percentage. I'm sorry, that would be a dollar amount. The coinsurance is a percentage that you pay after you meet your deductible. And Medicare uses those terms interchangeably, just for the record. So it could be a dollar amount or a percentage. And the cost share is the amount that you pay out of pocket, including your deductibles, copays, and coinsurance, but not your premiums. So AdCare, which is adult and disabled care, is really full Medicaid. You have to be at 100% of the federal poverty limit level. The income amounts are here $1,275 for a single person or $1,723.50 for a married individual. And your assets can be no more than $2,000 for a single person or $3,000 for a married individual. Assets do not include a home, a car. It's one car in the household, even if you're married. The second car is considered an asset. And things that are considered assets are things that are liquid, like bank accounts, IRAs, retirement accounts. Assets don't include your jewelry. If you have an art collection or anything really in your home, it's only things that are liquid. With AdCare, Medicare will pay the Part B premium, any copays, and any deductibles. It will include prescription drug coverage with very low copays, or it may have other benefits. And these numbers include what's called a $20 disregard, meaning that Medicare doesn't count the first $20 of income, regardless of whether it was earned, for example, by working, or unearned, for example, alimony or Social Security. So if you look at another chart, you may see that these numbers are $20 higher than some charts may show, and that's why, because we're including the disregard in here and some charts don't show it. So the second program that's eligible for people at lower income is called QMB, or Qualified Medicare Beneficiary. Again, you have to be at 100% of the poverty level. Your income is the same as it is for AdCare, but you can have more assets, significantly more. So you can have $9,430 for a single person and $14,130 for a married individual. And with this, Medicare will pay the Part B medical insurance premiums, copays, and deductibles, but it won't cover your prescription drug coverage, and there are no other benefits that come with QMB. SLIMB, or the Specified Low Income Beneficiary program, is for people who have incomes at a slightly higher level. So there's a range of between 101 and 120% of the federal poverty level. The assets are the same as they are for QMB, and it will pay your Part B premium, so that $170.70 doesn't cover any copays or deductibles. There's no prescription drug coverage or any other benefits, and you can get benefits 3 months retroactively from the month of eligibility. So there's a look back period on that. OMB, which is the additional low income Medicare beneficiary program, again, has a even higher limit for income of 121 to 135% of the federal poverty level. The asset range is the same, I believe, as it is for SLMB. Medicare will pay the Part B premium, and you can access benefits 3 months retroactively from eligibility. This program is not an entitlement, and there's a pot of money for it. And so it's first come, first serve. When the money runs out, this program doesn't exist anymore. Only the people who are in the program remain eligible, and then you have to reapply again for the next year. We can help everybody apply for these programs. So then there's also a spend down, which some of you have probably heard about, which is a monthly deductible that's set by the Department of Health and Human Services based on people's income and assets over the Medicaid allowable amount. After the deductible's met, you get full AdCare Medicaid for the rest of the month. You need to show proof of medical expenses monthly. They don't have to be paid. They can be in collections, but you have to show that you've got X amount of medical expenses above the monthly deductible amount, and then AdCare will kick in. You have to apply for it, but once you apply and get a spend down amount, it will kick in. And your assets are at the AdCare level of $2,000 for single and $3,000 for a married couple. And then there's also SSI, Supplemental Social Security Income. That's for people who have significantly less income. The asset level, however, is the same, and it's full Medicaid if you're eligible for SSI. You don't need a separate application. It will be automatic, and that's applied through the Social Security Administration. There's other ways that people can save. There's Extra Help Low Income Subsidy, which if people are having trouble paying their Part D premiums and deductibles, they can talk to us about applying for extra help that can pay for those things. We advise people, if you have people who are on expensive brand name drugs, to talk to their doctors about switching to a less expensive drug or a generic that might work just as well. We can't tell them to switch, but we can advise them to talk to their doctor. You can compare prices at pharmacies, and this is something people don't know, and this is something we do a lot of work on. There can be $1,000 difference, for example, between Walgreens and CVS for a particular drug, depending on if it's in network or not. And people are welcome to go to any drugstore that they want to go to, but you want to know when you walk in the door if you're going to be paying a lot more for your drugs than if you go across the street to another pharmacy. And when we help people choose a plan, we also look at the pharmacies that they like to shop at to help them to understand where the lowest price to go is. Again, reviewing plans annually. There's the pharmaceutical patient assistance programs, which we can help people with. Those are you've seen those commercials. If you can't afford your prescriptions, AstraZeneca may be able to help you. Well, we know who those programs are, and we can help people with applying for those. And then there's the pharmaceutical discount cards like GoodRx, and there's a Michigan one. I'm not sure if Washtenaw has one, Oakland has one. And those are legitimate, and those often can save people money as well. I don't know, do I have a little more time, or am I kind of good? I have a little more? I'm done? I can't. Can you unmute? I don't know what the thumbs up meant.
No, I'm so sorry. Yeah, that was vague. No, you're good for time. Keep on going.
Okay, good. So Medicare offers some preventive services, and one of the best ways to save money on your health is to not get sick in the first place, or to find a problem that is find a problem early when treatment options work best. So original Medicare, if you have it, will pay you generally pay nothing for your preventive services if your provider takes Medicare, although there may be a co-insurance for the visit. So if you go in for some tests, they may be free, but the doctor may charge you $20 or something to go in. And if your doctor doesn't take Medicare, you're going to end up paying more. but most doctors do take it. And in a Medicare Advantage plan, you may have a copayment or coinsurance that goes with it, but they have to cover all of the same tests and preventive services. When you're first eligible for Medicare, you get a welcome to Medicare visit. And it's a one-time visit within the first month that you get your Part B, and it will review your medical and social history, your height and weight. They'll do a vision test, education and counseling, and you may get referred for additional screening. And how do you get your welcome to Medicare visit? You call your doctor and you say, I want my welcome to Medicare visit, and they should know what it is and they should schedule you accordingly. And then you get a yearly wellness visit as well, which is available every 12 months. It's similar to the welcome to Medicare visit. And it's not exactly a physical. I'm not exactly sure what the difference between the physical and the yearly wellness visit is, but I've been told it's not a physical. So you may end up getting a physical with it. And therefore, if you get a copay or a deductible, you may have to pay that for your physical. But those are things that are really important, especially as we get older. The next few slides, and everybody I think can get a copy of these because I sent them to Stacy. So I'm not going to go through them in any depth, but these are some of the wellness and preventive services that Medicare covers. Mammograms every 12 months at no cost. Prostate cancer screenings every 12 months at no cost. All immunizations are free of charge. Every single one of them now, including Shingrix, which was a big one. However, if you go to your doctor to get it, again, your doctor may charge you for the visit, but they can't charge you for the immunization. Glaucoma tests, HIV, diabetes screening, and again, all your immunizations. And then the other thing that we do is we help people with fraud, abuse, and scams. Scams are a billion-dollar industry affecting our seniors, and seniors are the most likely people to get scammed. Some examples can be if they call and someone says that they're, or you get a bill for a service that you never received, someone's using your Medicare or Medicaid card, or someone coerces you or uses false information to mislead you into joining a plan. If someone calls and says they want you to verify your Medicare number because Medicare's issuing plastic cards, that's a scam. First of all, Medicare isn't issuing plastic cards. Second of all, Medicare knows your Medicare number. They don't need you to confirm it. And Medicare's never going to call anybody. So if people get calls from Medicare or the IRS or whatever, those are scams because these places don't call. The callers, though, can be very insistent on these, and they'll often ask for immediate payment. And it can be really scary for a senior, especially if they're living alone, to be told that like it's not a Medicare scam, for example, but there's porn scams out there that people have illicit pictures of you, and they're going to post them unless you send them $500 in Target gift cards. Well, it's a scam. They should hang up. They can call us. They can call the police department. We will help them. We will help them report. We'll help protect them. And these are two numbers that people can call. The MAP number, that's the same number, the 803-7174, it's the same number to call for individual counseling. And then there's the S&P hotline. S&P stands for Senior Medicare Patrol. I did not make up that name. It's a national name. And it's a new hotline number for people who think they might have been a victim of a fraud or a scam. And we always tell people to please don't be afraid or embarrassed to report. Scammers are very, very tricky. It can happen to anybody. Just today, I got an email from my CEO, I thought, and I replied to it, but it wasn't from him. And I do this for a living, and you can't always tell what it is. So don't be embarrassed, and please call, because if people don't report things, we can't resolve them for them. And then this is just who we are. We are in, just like the Cancer Support Network, we are in every state in the country, but we're all our own individual nonprofits. We provide free, confidential, unbiased information to help people make their best Medicare and Medicaid needs. We are staffed primarily through highly trained and certified volunteers who are experts in understanding their Medicare and Medicaid. We are not affiliated with any insurance companies, and we are not licensed to sell any insurance products. We're not allowed to give recommendations on insurance either. We can just break it down to people so what their choices become obvious. We can help people understand their Medicare, enroll in their plans, identify and report Medicare fraud, abuse, and scams, assist in enrolling in low-income programs. We can also help people with appeals if they've been denied services. And we can do a number of other things. So if somebody has a Medicare issue and they don't know where to go, they should call us, because if we're not the right place, we'll help them find a place. That's what Ageways will do as well. So we counsel over the phone, in person, and on Zoom or Teams. It's confidential. Nothing is too trivial, and we often deal with very complicated issues as well. For more information, we can send you a Medicare and You book. You can call Medicare or you can call us. Ours is the big bold number at the bottom of the page, 800-803-7174. And this is our mandatory funding statement that we have to put on every presentation. And that's me, Sherry Smith. And the map at ageways.org is our general mailbox. If you want to reach me, it's smith@ageways.org, or you can send to map and just say, want to speak to that regional coordinator person, and the email will get to me. And that is my dog and pony show. So I'm happy to answer any questions. I know that's an awful lot of information in a very short period of time, but it gives you an overview, and you'll have the slides to look at, and you know who to contact or who to send your folks to. And I might also add that we are always looking for volunteers. It's a pretty extensive training program, but if anybody wants to be a volunteer, you can contact us and we'll talk you through it. And I also just want to say a shout out to Trevor. That was a good presentation, and our paths keep crossing. I'm the person who also worked at the Bluebird table at the event you did the other, like a couple weeks ago. Anyway, any questions?
Yeah, thanks so much for the presentation, Sherry. There's at least one question in the chat. Desiree asks, would VA healthcare possibly qualify as credible coverage for someone who did not sign up for Medicare at age 65 but has been receiving VA healthcare coverage?
No, VA doesn't qualify as credible coverage, remarkably. I don't know why, but they don't. Generally, people who are getting healthcare through VA tend to get their drugs through VA. So if they do sign up for a plan and get their medications through the VA, then they don't have to worry about getting a Part D plan, and they don't have to worry about a penalty with Part D. But if you've got a client who's getting their healthcare through VA, if they call our 800 number, we have a couple counselors who know VA real well. I don't. And we can have them work with one of those counselors to see what we can do to, sometimes we're able to get penalties waived, you know. I just didn't know about it. I thought it was credible coverage. How could a program that the government's providing not be credible coverage? And we can sometimes help out. So they should call.
And then Sheila's got just a request. Can you put back up the contact information for MAP?
Sure. Should I put it in the chat?
Yeah, that'd probably be good.
Okay, so it's MAP and our 800 number. And if you call our 800 number, you're probably going to get voicemail, because we only have one person answering the phone. We get about 100 calls a day, but we will call you back. MAP at ageways.org, and I'm Sherry Smith. And you can contact me directly, but don't give it out to your clients, please. I don't do as much counseling, and when the clients call, I always feel bad that, I don't want to bounce people around to different people.
Makes sense.
Okay, any
Um,
other questions?
Yeah, there's one question from Sarah. Is the
Mhm.
Medicare Savings Program the same as one of the following programs you presented? And then they
It-
list out QMB, SLMB, ALMB.
Yeah, Medicare saving, those are all kind of under the Medicare Savings Program umbrella. And the ag care is the most comprehensive of that.
Okay. And then the second part of her question is also, are applications for QMB, SMLB, ALMB programs submitted through MyBridges?
You can submit them through MyBridges, yes. They can also submit through us. One thing I want to add on that is make sure that when someone submits, that they say somewhere on the application that they want all the programs that they are eligible for. We've had people rejected from ag care when they applied for, they should have been able to get Quimby and they weren't, and the worker said, well, you should have said that you wanted Quimby. Well, the beneficiaries shouldn't have to say which one of these programs they want. They want the most, and it should be the worker who, if you don't qualify for the highest level, who should look to the next level down. It's kind of annoying. We have a lot of issues with MDHHS workers sometimes, but we're fighting right now. The 16 regional coordinators across the state are fighting to get a liaison with Medicaid so that we have somebody that we can bring these problems directly to, rather than, whoever answers the phone. I am looking at Sarah's question about does MAP help navigate community spousal allowance programs when someone goes into a nursing home? So yeah, there's a spousal impoverishment level that's income based, which is the next note down there. And if you want it, email me and I can send you the 2024 spousal impoverishment rates. They are what they are. We can't change them. But what that means is, though, for somebody whose spouse is going into a nursing home, the government graciously allows the spouse remaining in the community to not have to live at the poverty level. So there's a certain amount of income and assets that they're allowed to keep so that they don't fall below the poverty level. And I'm sorry if my biases are showing.
I just wanted to note that Alice over at our local Washtenaw MDHHS is happy to connect folks to the appropriate management staff for Washtenaw County,
Oh,
Michigan Department of Health and Human Services too.
fabulous.
It's really great that you can liaison for us that way.
Yeah, Alice, if you wouldn't mind emailing me all your contact information or putting it in the chat. We just got a new site coordinator for Washtenaw County, and we're looking to do things a little bit differently. And if we can make some connections, that would really be fabulous, because we know that there's some good workers out there, and it's just the ones that we tend to get on the phones are not always those people. So if we can get connected with people who can really help us out, that would be fabulous. Thank you.
Yeah, and the local Washtenaw County MDHHS, they also send out monthly, and I forward it to the Barrier Busters group, the contact information for Washtenaw County DHHS staff too, including who the supervisors are.
That's really good to know, because since they changed from having caseworkers to just whoever answers the phone when you call, we found it's not been real beneficial for our clients. So if we can work more directly with the local office, which has always been the recommendation when, rather than calling the the state number, that would be so much better.
All right, I don't see any other questions. Last call for them?
And I apologize, but I have to leave early because I have another commitment.
Yeah,
I want to thank you for having me here, and please don't hesitate to reach out if you have any questions or to send your folks our way. And we will be doing a number of open enrollment events in Washtenaw. So look out for them at senior centers, at libraries, and I'm not sure where else. So look out for them, and we can send you information if you send us some of your information. Thank you.
thank you so much, sir. All right. All right, the last agenda item that we've got is just our funding update. As noted when we sent it out, I think it was, I can't even remember, I think it might have even been the first day in June. We are currently out of all of our flexible funds. We do have the City of Ann Arbor Water Utility Assistance Fund, and that's constantly rolling. But for June, we are out of funds. There is a little bit of good news for next month and for the rest of the year. We've been able to secure some additional funds from Pittsfield Township, Ipsy City, and the United Way of Southeast Michigan. So that's going to be moving our kind of like total available barrier buster funds to about $35,667. So hopefully that'll help a little bit. You know, I'm still concerned about the fact that we start pre-pandemic, we had an annual budget of between $250,000 to $350,000 in any given year. And you know, in 2023, we had over $1 million in assistance, and this year is going to be looking pretty similar. We've got a budget of about 1.3, and yet even with that, we're running out of funds very, very quickly within the month. I think the other potential game changer is you folks would probably saw DHHS's announcement the other week that utility state emergency relief is no longer available for the rest of the fiscal year. So remember that SER is on a October to September fiscal year. So there won't be any utility assistance SER available until October 1st of this year. And that's a pretty big game changer because their 2020 expenditures for utility assistance was close to 1.9 million. And we've got another 3 months to try to get by. All right. Is there any questions about the Barrier Busters funding report? All right, hearing none, we're going to close up the meeting. Thanks everybody for attending. Remember for July, we skipped the Barrier Busters meeting, so look forward to seeing you all again in August. Have a good week.
Thank you.